Hi, everyone. This is Giovanna Giuliani from the California Healthcare Foundation. Thanks for joining today's webinar on integrating palliative care. We are very excited to have a great lineup of 4 speakers from St. Joseph and from Sharp Healthcare, and I'll introduce them in a minute. Just a few webinar housekeeping items before we go forward. As you know from what I just said, this session is being recorded. All participant lines are muted, so you won't be able to speak. We won't be able to hear you if you're speaking. But if you would like to ask a question at any point during the webinar, there's a couple ways that you can do it. If you have a logistical question, feel free to use the chat function and you can chat the host. But if you have a question for one of the presenters, please feel free to chat all, and I'll be moderating that and looking for questions as they come through. If you prefer to ask your question verbally, there's a raise hand function kind of towards the top right underneath the panelist or participant names. You can click on that and we can unmute you, but you can only do that if you either had the system call you or if you logged in to WebEx, if you dialed in after logging into WebEx where it connects your phone line with your name. Those are the logistical items, and we're missing Dr. Boyd's photo on here for some strange formatting reason. So you all will have to imagine what Dr. Boyd looks like. But what I'll do is just do a quick, I'm going to do quick bios of all 4 speakers at once so that we don't have to interrupt the presentation as we go through. But like I said, we are very lucky to have 2 organizations represented on the call today. The first organization to present will be St. Joseph Hospital. First, we have Dr. Brian Boyd. He's the co-medical director of the Inpatient Palliative Care Consulting Service at St. Joseph Hospital. And he's also medical director of the St. Joseph Home Health Palliative Care Program. He is the chair of the medicine department and the pain committee chair at St. Joseph's Hospital, and he was recently the recipient of the Senior Care Hero Award for Outstanding Physician by the Senior Serve of Orange County, as well as the Physician of the Year from the California Association for Health Services at Home. He's board certified in neurology, pain medicine, as well as pain management, and additionally in electrodiagnostic medicine. Our second speaker from St. Joseph Hospital is Dr. Melvin Sterling. He is also the co-medical director of the palliative care team at St. Joseph Hospital and is a clinical professor of medicine at the University of California, Irvine. Dr. Sterling was the founding chair of the Palliative Care Task Force at UC Irvine, where he established one of the first programs in palliative care in an American medical school. He also served as the medical director of the Orange County VNA's hospice program and as chair of the End-of-Life Care Curriculum Committee of the CMA. Dr. Sterling was one of the first physicians nationally to be certified to teach EPIC, which is Education for Physicians on End-of-Life Care. He is board certified in internal medicine and hospice and palliative care medicine. And then our speakers from Sharp Healthcare, we are lucky to have Dr. Daniel Hofer. He's the CMO for Outpatient Palliative Care and the Associate Medical Director for Utilization Management at Sharp Reese Steele. He's a board-certified family practice physician and has spent over 25 years working in nursing homes and with geriatric patients. He is also an EPIC-trained physician who has been the visionary for development of an evidence-based disease management care model for late-stage illness, and he frequently presents at educational conferences on local, state, and national level to physicians and other healthcare providers on issues surrounding the timely provision of end-of-life care. And then our second speaker from Sharp Healthcare is Susie Johnson. She's the Vice President of Sharp Hospice Care, and she's been the visionary in developing a home-based palliative care consultation program for heart failure, COPD, and dementia. Her leadership and passion for excellence in end-of-life care has helped to make Sharp Hospice Care the first hospice in San Diego to offer a weekend-long bereavement program for children, the first to offer a memory bear program, and the first in San Diego to open 2 hospice homes specializing in end-of-life care. She serves on the California Hospice and Palliative Care Association's Board of Directors and is the 2011-2012 Board President. She's also a member of the National Hospice and Palliative Care Organization's Managed Care Work Group. So with that, I will turn it over to St. Joe's.
Okay, there you go. Good afternoon. Thank you for the introduction. This is Mel Sterling, and I'm going to talk about our inpatient service. And I understand I have
all the way up there, the arrow by Palliative for a moment.
I'm
Keep
sorry.
going up. Keep going up. There.
Okay. Thank you. I understand I have 10 minutes, and I've never spoken in such a short time in my entire life, but we'll see what happens. So I'm going to start with talking about why, if I can, is that it?
Yeah.
It is. Okay. So we have a medical model for our palliative care service. It's a hospital consult, and it's, I think, the ideal model. There are two co-medical directors. You'll hear from the better one in a few minutes after I'm done. We also have a medical social worker. We have a chaplain, and we have two nurse practitioners, and we're trying to clone both of them, having difficulty doing that. So why? Since you got up this morning, we have added 10,000 new people to the Medicare rolls. 10,000. So the U.S. elderly population is growing, and that population actually, we're keeping them alive a lot longer. The life expectancy for Americans has increased dramatically, and in my own practice, I have patients that are over 100 years old. 100-year-old people have a lot of chronic disease, and those chronic diseases cause a lot of suffering. It's costly. It's costly in terms of the financial cost of taking care of those patients. It's also costly in human costs, the cost of the suffering of the individual and the impact on the family and or other caregivers. So we developed our program after looking at what the population is and what the disease burden was, and how we could help the patients, how we could help the family and still control the costs, and in fact, how could we decrease the cost? And it turns out, as you will see, that it is actually possible to decrease the cost while improving care. I think probably everybody that has signed into this call is familiar with what the problems are. The question is, what is the solution? And we would suggest that the solution for this patient population is to have this kind of a robust palliative care team that can address all aspects of suffering. And then finally, in order to start our program here at St. Joseph Hospital, what we were doing had to be consistent with the ethics and the values of this hospital, and that is certainly the case. So how does it work? There are nurse practitioners in our hospital. It says 10 to 12 hours per day. It's actually longer than that, as the families of the nurse practitioners can tell you. Consults are called in to the doctor or the nurse practitioner from the referring physician. That's ideally the case. It doesn't always happen that way. Sometimes an order is just written for a palliative care consult. We strongly prefer to have the reason for the consult and background information shared by the referring physician. Well, what happens next is our nurse practitioner will see the patient, review the chart, speak to the bedside nurse, the case manager, and very often these patients have been referred by a doctor who's been managing palliative care aspects of the patient as an outpatient. The nurse practitioner or the doctor will commonly contact that referring physician. A history and physical will be performed, and it's a complete history and physical, but the focus is really on what the palliative care issues are. So then the medical director will see the patient, hopefully with the family if there's family involvement and if there are family concerns, and we will formulate a plan. And that plan is a collaborative plan. It's typically done with conversation between the doctor and the nurse, and then if there are issues where other members of the team are indicated in the very early, early involvement, then we will have other members of the team involved in the initial assessment. But typically, it's the physician and the nurse practitioner. The social worker, spiritual care person, will usually see the patient later, and then will follow up on a daily basis if needed. Every week, the whole team meets to discuss the case and any particular problems that may exist. So, what happens? Well, we look at what happens, and we use indicators that are based on CAPC, on the Center for the Advancement of Palliative Care, and we try to be proactive in both our follow-up and our interventions to manage pain and symptoms. And of course, one can't do that unless there's an adequate assessment of what those problems are. And so we use the Edmonton Symptom Assessment System, and the nurse practitioners do that on every patient. What we have found is that we save money. We save money, and we save not only the money, but we save the human cost that's associated with unnecessary hospitalizations and often unnecessary interventions, surgical interventions, non-surgical, but other interventions, perhaps invasive procedures that are not typically surgical. We will often avoid unnecessary imaging procedures and sometimes unnecessary consultations that might have been required before the palliative care team came in, and we are able to define whether or not those are necessary. Often they will not be necessary. And most importantly, this gives us the opportunity to clarify the goals of care. When we started doing this, there was a thought that what we needed to do was to clarify the goals of care with the patient. Well, that's certainly the case, but we also need to clarify the goals of care with everybody else involved, and that's the patient, that's the family or other significant people involved with the patient, and it's very often important to clarify the goals of care with other physicians involved in the patient's care. My colleague, Dr. Boyd, calls it introducing truth-telling, which I think is an excellent description of what needs to be done. So, how does it work? Well, this is our data. We started out in 2005 with 189 consults, and you can see what's happening. We're now up to almost treble the number of consults per year, and I think that's likely to keep happening. Did we miss a slide?
I'm just thinking you've got a minute.
Oh, right. Okay. Thank you. Okay. So this is just some data that I think is incredibly important. We have a lot of interaction with our critical care team at this hospital. And what you can see from our data is that the total length of stay has gone down as the cost of care has gone down, mortality has not increased. So let me get to the bottom line. What have we learned from what we've done? What we've learned is that if you're going to do this right, as Hillary Clinton used to say, it takes a village. Well, it takes a team. So it's very important to have an interdisciplinary team. And the interdisciplinary team, the reason it's important is for the quality of care and also to prevent burnout of the individual team members. We've learned the importance of evaluation and treating both the physical and the psychological and spiritual distress, or what we would call total pain, and to treat that as aggressively as we treat the physical symptoms, and to remember the role of the palliative care team is to support the patient, the family, and the referring doctor. And my 10 minutes are up and then some. Thank you for listening.
Thank you, Dr. Sterling. It's Dr. Brian Boyd, and Dr. Sterling has, I think, eloquently described our experience on the inpatient setting. I'm fortunate enough to also be surrounded by a very strong team in the outpatient setting. One of the other hats I wear is the medical director of the St. Joseph's Home Health Palliative Care Service. And Rose, if we can go to the next slide. Our team is highlighted here on the slide. Liz Wessel coordinates everything and does the outreach calls. We have nurses both in the field and present at the conference, social worker, pharmacists. We have close collaboration with our hospice colleagues, and the home health folks and the nurses have had 8 hours of orientation as part of participating in this. We can go to the next slide. So why the program developed? In the outpatient setting, it was identified that there were gaps in care where patients weren't quite ready to transition to hospice but did need advanced supportive care. And there was a need for improved pain and symptom management, and we wanted to cut down on frequent readmissions when the symptoms were out of control. So our service does offer expert medical advice to the primary care physician, the patient's consulting physician. We get our social worker involved with every patient at the time of the referral to identify those needs. And the patient's condition, as it perhaps declines, we see one of the values of the program is providing a smooth transition to hospice where appropriate. We have some numbers in that regards. We wanted to be proactive in dealing with the patient's symptoms to avoid the potential suffering. So how does this work? I'm on site at our home health facility every week, Wednesday afternoons, where we have the presentation of the patient, review the records. The nurse will give a presentation either in person or more commonly, we contact the nurse by phone when she's out in the field. She'll pull over and present why this patient was brought to conference. Liz Wessel, who coordinates things, can identify the patients that are appropriate for conference through outreach calls. The nurses in the field can add the patient to the conference schedule, and that's how that works. Once we conference a patient, this commonly will involve making a phone call to the patient. And I must say that this is one of the more gratifying aspects of what we do, because we're able to establish directly what the needs are and tailor-make the recommendations. Recommendations are then faxed to the treating physician. We have a follow-up phone call with that physician to see if they feel these recommendations are appropriate to implement, and then they're typically implemented within 24 to 48 hours from there. We do have some quality outcome data that we've been able to collect. The indicators are based on clinical practice guidelines for quality palliative care, the National Consensus Project. We do proactive follow-up and interventions to manage these symptoms, and we hope and have data to show that we prevent costly and unnecessary rehospitalizations. We look at the satisfaction data from Avatar. For the last 5 years, we've had a mean of 90.68, and we're proud of our rehospitalization figure being 12%, where the national average is 24. So pain is one of the more common things that is assessed. 77% of the time, it's improved. We, of course, prescribing the class 2 narcotics are particularly sensitive to bowel programs, and we're at 70%. We can document 100% of the time that do not resuscitate was discussed with the patient. Pre-hospitalization emergency medical forms are present 67% of the time. Our data shows we control the symptoms 83% of the time. And the complex case conference every 60 days, we're able to achieve that, as you can see, 82%, and when the symptoms worsen as well. Again, what we find helpful is that we, in home health palliative care, have offered a pathway to transition the patients to hospice. And I must say that this is particularly valuable when we initially see the patient in the hospital, particularly if it's a new diagnosis, perhaps of an already advanced illness. Commonly, patients and their families, as we all know, aren't ready to sign on to hospice, despite perhaps it being medically necessary. So commonly with these patients, we will discharge them on home health palliative care because we have the outpatient resources available to transition them to hospice when they're ready and when it's appropriate. So what we've seen with our data in the outpatient setting, patients are referred to hospice 40% of the time. Of those 62 patients who we referred, 100% of the time they were admitted to hospice. And our length of stay numbers we're pretty proud of. The median length of stay is 13 days. The average is 32. And for those staying 7 days or longer, it's at 66%. So we are able to try to have earlier referrals to hospice and better utilization of those services, and to hopefully then minimize their suffering. So when we look at lessons learned in the outpatient setting, we feel that there's a seamless provision of care from inpatient consultation to the outpatient setting. And one thing I would share with the group is with our recent recognition from American Hospital Association Circle of Life, they felt this was one of the strong aspects of our program in providing this transition from inpatient to outpatient. We feel, of course, it is valuable to help this transition both from the patient and the family perspective from palliative care to hospice. We have seen, and our data supports, that we've had a significant impact in reducing hospital readmissions and, of course, reducing the impact of the stress for the patients and families as well. Dr. Sterling, do you have anything further to add in this regard?
No, I think you've really covered it very, very well. It's a seamless program. I think it provides a tremendous resource to our healthcare community. So just thrilled to be a part of it.
And I would
Thank you so much.
One of the aspects that I think is particularly helpful is reaching out directly to the patients with a phone call, getting their direct impact. I think that we've found that we've been very successful in having our recommendations implemented by the treating physicians who do indeed seem to trust our judgment from experience and go with those recommendations commonly.
The other thing that we do is we do reach out to the physician and the palliative care community in general. We have a palliative care journal club that meets periodically, and in fact, we have a meeting coming up. So it provides both education and networking venue.
And I can also share that we're in, we hope, the final stages of establishing a formal outpatient palliative care clinic. So I think with that, we'll turn it over. Now, I'm supposed to shift the ball, I understand?
Actually, Canel can go ahead and do that, so I'll ask Canel to switch it to Sharp. And then I'll ask St. Joe's if you could put your phone on mute for now, and then when we get to the Q&A session, I will ask you to unmute it so that you can answer questions from folks. So Canel, are you able to, oh, you already did. Okay, great. So Sharp, if you can navigate to your presentation at the top. Great.
So, hi, this is Dr. Hofer. Nice to have everybody here today. What you're going to see about Sharp Hospice Care's outpatient palliative care program is there are many similarities to St. Joseph's program. However, ours is primarily an outpatient-based program, and I will point out as many differences as well. Sharp is a very large organization. We are highly integrated vertically and horizontally. However, we recognized in our hospital system that there were some inefficiencies. And if you look at the structure of Medicare reimbursement for the last 50 years, most of that's based on what we call a reactive model of healthcare or the acute care model of disease. Once the patient's broken, we'll fix them. However, we have the knowledge and wisdom now to know that 90% of patients will die from the predictable end stages of medical conditions, and we don't need to wait until those predictable decompensations occur to become involved with managing these patients. Susie Johnson and I also recognize, working concurrently on hospice, that we would take many patients on hospice, and we're going to get the data today for congestive heart failure, although we have programs for COPD, cirrhosis, cancer, dementia, and frailty, and we'll be getting other disease-specific programs. But we would take these congestive heart failure patients onto service after they had literally been admitted to the hospital 15 times in the years prior to service. And because of the management style we had, we would manage them so proactively and so aggressively, they would never decompensate again for another 2 to 3 years until they finally died. And we looked at the models and said, well, what model is actually doing a better job managing these patients? You can look at medical evidence as well, which shows that proactive management, and I think there's enough of that evidence around now, prolongs life and lowers cost. So the principles of the transitions program were simply to use our hospice-based medical evidence and move it upstream. Now, I've been a family physician for 25 years, and there's a gap in the healthcare industry. And that gap from the primary care physician side is that point for which I have a patient in my office who is on excellent medical care, but being sent home with their elderly husband or spouse, and they do not have the capability to keep themselves from decompensating. And there's no service we can send out for those patients at this time because they don't have a Medicare Part A skilled need. And it is really simply a cultural phenomenon that we need to hospitalize these patients once before we become aggressive. I've worked with children for 2 decades, although I don't do that now, and in pediatric care, we do what's called anticipatory guidance. We advise the caregivers and families about how to manage patients before they become ill, their children, so that they don't, for example, drown or choke. Well, we know what's coming for our congestive heart failure patients, and we know how to manage it. Why would we permit them to drown or choke or suffocate with CHF, COPD, dementia, or these other conditions? So the transitions program is based on the principles of not only proactive disease management, but proactive management of the caregiver, proactive psychosocial management. And one of the other things that we do is we give a very accurate description. I heard truth-telling before. I would like to reinforce that. The healthcare industry happens to be polluted with healthcare vernacular, which is a little bit emotionally manipulative. Words such as curative, full care, aggressive care. Ironically, we are keeping these patients alive longer at better quality of life and lower cost with aggressive hospice and palliative strategies. So,
Dr. Hofer, this is Giovanna.
Yes.
Sorry to interrupt. We had a request to either maybe speak a little bit louder, or if you can turn up the volume on your phone, that might work as well.
Can you hear me better here?
That's perfect.
Okay. So when expanding the care continuum, we have to look at treating people in their home setting, which is where they want to be. That's where the best medication and treatment reconciliation occurs. We look at late-stage disease, particularly ones that are filled with chronic decompensation issues. We need skilled clinicians, palliative hospice care providers, physicians that look at the most aggressive outpatient management. And you have to work within a system that has a flexible model, and obviously we're looking for cost efficiency. We created then the 4 pillars of the transitions program, and the first one, of course, is medical management. And when I first started giving these talks, I would not talk about the medical management because I always say we tend to do what we know and we don't do what we don't know. And there's lots of models out there such as Cardiacom or other excellent medical management programs. But in late stage and end-of-life care, we have to look at these other pillars: prognostication, professional care for the caregiver, and how much that actually improves outcomes on those other levels, and then advanced care planning. And disease 1, these are the providers of medical management. We do go into the patient's home. When we started our CHF program, we actually hired a hospitalist out of the hospital and a cardiac nurse specialist out of the hospital and just moved them into a different model and said, well, let's keep those decompensations from occurring in the first place. Medical point 2, medical pillar 2, is evidence-based medical prognostication. Unfortunately, that's a lost professional skill. But as we do with children, if we can relearn that professional skill in the outpatient environment, we can do markedly better. I'm not going to go through this study in particular except to say this was out of the British Medical Journal, and it showed that when we come to prognosticating currently, specialists and primary care physicians, the vast majority of physicians, about 2/3, are markedly overly optimistic. I can tell you as a family physician, we see this. They were off on average of those 2/3 of physicians by 530%. So I'm in my office taking care of a patient who I know is approaching late-stage disease, and I refer them to a specialist or to one of my colleagues. And if I'm not confident in my colleague's ability to prognosticate, what has the healthcare industry done? Well, we've institutionalized over-optimism. And the only people who are more overly optimistic than physicians, according to medical evidence, are patients and families. So you can see where the problem starts. I happen to work as an expert witness for nursing homes, and I'm routinely defending patients and families, defending physicians in the nursing homes, because the patients and families' perspectives are so discordant with what the medical evidence actually showed. And one of the goals of our transitions programs is to be sure that the patients and families know exactly where they are in the treatment pathway. Why? Because they have to be making decisions that are consistent with their goals of care. We don't want to leave the patients and their families emotionally unready for what we know are inevitable outcomes. And of course, it's nice to have good credibility in the healthcare industry that you're the person or you're the team to go to when you want to get the truth telling. For Pillar 3, we deal with evidence-based medical care for 2 reasons. Number 1, we know that caregivers survive when they are provided hospice and palliative supportive care over non-hospice case control. So the caregivers, ironically, live longer. The other issue is we engage the caregivers to look for the early signs of change in the patient. And so we're not just relying on the patient to change, but we provide a 24/7 service for that caregiver to feel valued in helping to manage that patient. And they are some of the best early warning system advisors that we have so that these patients don't have to get to the point of decompensation where they're needing to actually go to the ER, to the hospital. And also we deal with advanced care planning. You heard about that as well. We deal with this in the outpatient environment. We do not want to be reconciling issues for the patient and the family in the emergency room, in the ICU, or in the hospital. We know what is going to happen for the natural progression of a patient's chronic medical illness. So what we do is we talk about when this happens, not if this happens, and we do it when the patient is not under duress and has capacity. And we say, with the family there, all of those people who would show up, we say, what would you want us to do if this inevitable consequence occurred? We know that historically, and I would say even with PULSE, it's not yet disease-specific. And so we talk about disease-specific issues, and we know by medical evidence that advanced directives are just too difficult to interpret. Sometimes they're contradictory. They tend to be avoided when patients are in the hospital or they're superseded. We all know these issues, and patients are getting older. It's not just 10,000 more per day. Our patients are going to continue to age, and I think that life expectancy, if we get obesity under control, will continue to grow. As a physician in the office, I think my colleagues and I forget that it's probably a lot harder for that patient to get there than the 15 minutes we give them credit for. So walking across the room is difficult, finding transportation, they're financially restricted, they may or may not have family, and all of these other issues that we have to look for a new model to manage this population of patients. We use the Transitions program as a pre-hospice program. It is a concurrent program, so our patients are expected to continue to see their primary care physicians and specialists. When do we put these patients on service? Well, we expect the primary care physicians to recognize, and the specialists to recognize, that the patient is going to start utilizing the hospital as a tool to manage their late-stage disease. This particular presentation was for cardiologists, but we have this for our neurologists with dementia, and they happen to be our best referrers. They continue to see the patient, they provide us guidance, we make sure that guidance is applied effectively, and we do the palliative care aspects that you heard earlier in the patient's home. We do not prevent or discourage our patients from seeing their specialist or primary care physicians. We do not discourage state-of-the-art therapies. For example, a patient changes their mind, I want a new state-of-the-art intravascular aortic valve replacement. We say, great, but if most of them decide not to change their mind, we will continue to support them at home until they go on to hospice. We don't discourage hospitalizations. What we do is we encourage letting us come out to help them manage their condition before they would possibly even need a hospitalization, and we don't take over the medical management of the patient. I would tell you before I hand this over to Susie, we were able to achieve a 94% reduction in primary, not readmissions, primary ER visits and hospitalizations for our congestive heart failure population, and we're looking to publish data to show that per patient we are improving patient satisfaction, we are improving population satisfaction, and the cost decrease per patient is $27,000. So with that, I'm handing it over to Susie, and here she is.
Thank you, Dan. So the interventions of the home-based palliative care program, the registered nurse is the case manager, and of course we're educating patients and families regarding the disease process, early symptom recognition, how to manage their medications in their home environment, how to read dietary labels so they understand their sodium intake, and then we help them facilitate the development of a long-term care plan. And we also do the care coordination between the primary care specialist and the patient and family. And that helps quite a bit for especially physicians to interpret what's happening in the home environment. The staffing components of the Transitions program, which is actually operated as part of the hospice program, we have a referral and intake liaison. We have registered nurses, medical social worker, and then of course the physician. Those are the staffing components. An RN case manager has a caseload of between 50 and 60 patients. The RN case manager will have about 8 to 10 that are in the active phase, and we're going to get to the active and maintenance phase in a moment. And the remainder of the patients are in maintenance phase. We have a half-time social worker for 100 to 120 patients. Palliative care physician has ongoing oversight and consultation for the total program, which we have about 150 patients in our palliative care program right now. And that palliative care physician participates in our monthly IDTs. So we've structured the palliative care program along the lines of the hospice program and using the IDT and meeting not every 14 days like you have to do with hospice, but on a monthly basis. And then we have 0.8 FTE of a referral coordinator. We have 2 phases in the case management design. We have an active phase and a maintenance phase. The active phase is about 4 to 6 weeks and is a total of about 9 to 10 visits, including nursing and social worker visits. We use an algorithm so that on visit 1, these are the things that are done, visit 2, et cetera, all the way through about 6 visits for nursing. When patients move into the maintenance phase, the nurses are making phone calls every 2 to 3 weeks and then making visits as needed. We use the hospice program for 24-hour call availability, and that's part of the case management model, so patients and families have access 24/7 to a registered nurse. We do have an electronic health record, so all the documentation is easily accessible to the all staff. So I've gone over this slide in the maintenance phase. And this slide is something in a research article that we're getting close to publishing. The emergency room, this hospitalization and emergency room visit slide shows reduction for all-cause emergency room visits. So that would be whether it were heart failure or a fall or whatever reason would send somebody into the emergency room. 57% reduction in emergency room visits and a 54% reduction in hospitalizations, all-cause hospitalizations, once patients came on to the transitions program. As Dr. Hofer mentioned, the average total cost of care was reduced 43%. So the savings to the Sharp Healthcare system is about $27,000 per patient referred to the transitions program. This just shows the patient demographics for the study that we have just completed. And this is our satisfaction scores. This is an internal satisfaction tool that we designed, and we do this concurrently. And you can see that for the diagnoses that we have measured in 2011, we had very high satisfaction, and this is the percent very satisfied. It's really remarkable to look at these sorts of results and recognize the difference that we are being able to make for patients and families. And with that, we can say that the lessons learned really have been around using cardiac. When we started heart failure, we used cardiac nurse specialists. We do have an 80% transfer rate of hospice patients. Patients who are on the transitions program, 80% of them transition over to hospice. And we didn't include length of stay data and so on for the hospice program. For heart failure patients, the length of stay has gone up remarkably in the last several years since we've had the transitions program. And with that, I'll hand it back.
Great, thank you so much. That was perfect timing, and really impressed by the results that you were able to show. So now we do have some time for Q&A. I will let folks start chatting any questions that they have. But I did want to, before some people might need to sign off early, a few things. There will be no CIN December webinar because of the holidays, just so a note that if you keep that time held on your calendar, there will be no CIN December webinar. And there is also another poll on the right-hand side, and please fill that out just before you're leaving, just about how helpful the presentation was to you today, and then if you have any suggestions for follow-up from today's webinar on palliative care or for topics for future webinars, please feel free to put that in the question number 3 open response box. So I will be waiting for questions. It looks like Mari might be asking a question but hasn't typed it in yet, but I do have one already. And this is for both presenters. And then St. Joseph, just a reminder to unmute your phone so that you can answer the question as well. But just curious about what has been the biggest barrier to adoption of these programs or uptake and referrals and so on? Is it provider engagement in terms of understanding, you know, the difference between palliative and hospice care, or has it been patient and family engagement? I would love to kind of hear about that.
Okay, this is Mel Sterling at St. Joseph Hospital. And early on, making the distinction between palliative care and hospice was quite a challenge. I think here in our hospital, I think that has largely been effectively dealt with. Perhaps other members of the team could comment as well. My personal feeling is that the biggest challenge which we continue to struggle with is appropriate early referral for palliative care in patients with very, very serious disease, particularly oncology, but I can tell you that it is uncommon for us to get an early appropriate referral for an end-stage cardiac or an end-stage pulmonary. How about other team members? Any thoughts about that?
I can tell you on the transitions program, our length of stay between the palliative and hospice teams for a single congestive heart failure runs about 250 to 300 days total. And I would agree it's disease specific as to how long those lengths of stay are going to be. The biggest barrier is the cultural change, because I think in healthcare we're used to introducing a new technique, a new technology. People will pick it up rapidly. But what we're saying to the community and to physicians is, well, it's time to take a second look about how we learned about healthcare and learn what palliative and hospice care actually are. Since the vast majority of healthcare providers have had zero education in hospice and palliative care, they do not know how evidence-based, how effective, how valuable, and how aggressive these tools are. But I would agree, I think with Dr. Sterling, is that once they see what we're doing and they see that we're not taking their patients away from them but working concurrently with them, the vast majority are elated to work with us and solve a lot of the problems they had a hard time with.
Great. We do have several other questions in the queue, so we'll try and get through them. Thank you for answering that first one. One is, and I'll combine some of them because they're similar, is there a specific criteria that's used to target or identify cases for inclusion? And I think there's, in general, several questions about how you find patients. Do you screen them? Do you use particular criteria, or is it just referral?
This is one of the nurse practitioners from St. Joseph's in Orange. For our program, it's all referral. It's doctor to doctor or doctor to nurse practitioner. We take probably 99% of all referrals. The only thing I can think of that we exclude is addiction, which we have.
Try to exclude.
Yeah, we try to exclude. And, but other than that, we take all comers, but it is a.
But the nurses are common.
But I will say, though, the nurses and the case managers are oftentimes successful in getting the physician to refer the patient.
The other thing is we have palliative care triggers used to just stimulate some analytic thought to the patient and what could help.
Yeah, we actually have developed triggers for both the ICU setting and for the general ward. And when our intensivists make their rounds, that's right there. And our hospitalists are using that tool as well.
We've also found that 5 o'clock on Friday afternoon, there are a lot of referrals. That's a joke.
Yes. And I think that answers Christine's. I think that answers Christine. Short had a question about whether or not there's some screening for admissions, and it sounds like you're using this trigger tool on the inpatient side.
Correct.
Okay.
On the outpatient side, I can tell you is that people like a concrete answer, and I keep, having to answer, well, give me some data to look for. When you prognosticate, you should be looking at functional decline patterns, biometric markers, disease-specific labs, non-specific labs, and you use that in cumulative description of your patient. But the real key is what I mentioned before, is to start to recognize when the patient will start using the hospital as a tool to manage their late-stage disease. That is associated with significant suffering, and it's not necessary. And so that's the real key for admission to the outpatient transitions program. I mean, I can walk people through lots of hardcore data that I've put in a booklet, and Susie and I share with our colleagues, but it is probably as good as the LCD criteria for hospice. It's just hard to create specific concrete data. And the cost effectiveness is not there after you've let the patient decompensate.
One is, Dr. Boyd at St. Joe's, one other thing I would share is we've also developed a brochure, it's called Directions of Care, that we hand out to patients and their families in preparation for the family conference. And we address prognostic features at that point, both with and without treatment. And we talk about what I refer to as the bookend questions to help families make the decisions what kind of treatment's appropriate to accept, what's the minimal acceptable outcome, maximum acceptable burden. And when we take them through that goals clarification discussion, a lot of times it's a lot easier. And we do have some limited data with an N of about 40 that did show satisfaction with the family and guiding them through that process.
Also, as kind of an adjunct to that, we have a formal protocol for family conferences where we go through the issues. We provide a written record that can then be used to refer to in the future, and that helps the patient and the family raise the questions that are important to them. We found that to be helpful.
Great, thank you. So I think we have about 4 more questions. I'll try and get through them. One is, we talked a little bit about how patients are mostly referred, although you do have these triggers. Has there been any thought of applying sort of an absolute criteria and then allowing the PCP to identify patients and then allowing the PCP to review and maybe opt out versus waiting for them to refer? And then would you be willing to share your triggers for ambulatory referrals?
Yeah, we are more than happy if you contact us at Sharp Hospice Care. You can email me, daniel.hofer@sharp.com, or Susie Johnson at sharp.com. The answer is that we've looked into data mining, and you can do that, but it's a little bit hard. If you look at all the tools in prognostication, most of them don't have a lot of sensitivity and specificity if the majority don't. And so you have to use a combination of professional skills. One that has been historically devalued and we forget to use are functional decline patterns and ADL deficiencies. I work as a primary care physician and I individually teach family physicians and internists how to re-look at their patients, no longer just thinking about diagnosis and treatment, but diagnosis, treatment, and prognosis, even further upstream than was mentioned by my colleagues. And what we do is we say, if you put all these tools together, a picture starts to be created and you don't have to be surprised. And we know what's coming next. So it's hard to put it all on paper, although I was actually asked to write a book, but if you start writing a book, it's going to be too complicated and people won't read it. So again, it's biometric models, functional decline patterns, disease-specific and non-specific biologic data, and then actually looking at general prognostic tools such as is it male, what's their BMI, have they lost weight, are they depressed, do they have geriatric frailty syndrome. If you can look at your patient just as quickly as you read your vital signs and just say, think prognosis, you have a better idea about what's coming for that patient.
And what I'll do is ask Canel to put your email addresses that you just listed into the chat function so that if folks, the person who wanted the trigger for the ambulatory referral can use that. So two last questions. There is a question sort of about have you given consideration or had problems with media attention if something goes wrong in palliative care and it says and a denial of care is entertained? Do you have any experience or thoughts about that?
Well, we're actually perfect, so that's never happened to us. But that raises one other thing which is only vaguely related and something that I would point out, and that's that involving a palliative care team, I think, dramatically diminishes the risk of a lawsuit. And in fact, we've been running this program for 8 years. I've never been named in a lawsuit. If I've not been named in a lawsuit, that means the other physicians involved in the care have not been named in lawsuits because the attorneys always name everyone.
The other thing this is Dr. Boyd again, I would throw in is I might reframe the question. It troubled me by the phrase a denial of care. How I see our role for goal clarification is to present the facts and allow the family and patient to make the decision that's right for them. Does that sometimes enter the realm of what we as physicians see as futility? Yes. How to deal with whether you provide futile care, what we perceive as futile care or not, is a whole other discussion. But I've never seen our role as being involved with denial of care, but rather helping the patient and families pick what appropriate treatment is right for them. And I would share Dr. Sterling's observation is a lot of times it seems like they write a consult for involvement in palliative care and risk management at the same time. We come sailing in and we are able to calm the waters. So I don't see it as being a liability issue.
Thank you. There was a question about the structure of the visits for the, I think this is for Sharp, for the active phase. Could you talk briefly about what those look like? I think you said there were 9.
The algorithm?
Yeah.
Was that the, yes.
I think that's the question.
Okay. Well, it's basically what we've done is we designed the visits. The nurse makes about 6 visits in a 4 to 6 week period. And the visits are very prescriptive. So visit 1 would include the beginning education around what the heart does and, what it's supposed to do, early symptom recognition. The second visit would be something on diet and exercise and medication. And we just go through the 6 visits like that. And up to and including goals of care discussion and a pulse, completion of a pulse. The social worker visit, which could be 1 to 2 visits typically, is going to focus on caregiver issues, resource support, community support, a financial assessment, and goals of care discussion. So that's how we've designed the algorithm.
Great, thank you. And then I think we have, maybe we'll try and squeeze in 2 more questions very, very quickly. Are you using the PPS, the Palliative Performance Score?
Edmonton,
yes. Yes.
St. Joseph's is.
Okay.
Yes.
And how do you use it?
And so does Sharp.
Okay. Last one, regarding inpatient, how long between the nurse practitioner visit and the physician visit are all patients seen by the physician, and are nurse practitioners and MDs available 24/7?
All patients are seen the same day by nurse practitioner and physician. If it's weekends where our stocks are taking the call, then NP may see them, come Monday. Second part of the question was?
Yes, we have a 24/7.
Yes, 24/7. Okay, great.
Yes.
So I think we'll stop there. Thank you so much to our 4 speakers for taking the time to put together these wonderful presentations and for sharing your wonderful programs with us. For folks who are signing off, please remember to fill in the poll, the little survey at the bottom right about the webinar today. And if you have any other further follow-up requests about palliative care, please feel free to type those into the text box in number 3. Thanks so much, everyone. Have a great day.
Thank you.
Thank you.
Thank you very much.
Thank you.
Where's the off button?
The white is on.